MR enterography for Crohn's disease. Standard protocol means oral PrEP, IV contrast, an antiperistaltic agent, and a long scan time. Patients do this repeatedly over years. A study in this month's Radiology asks, what if you dropped the contrast and the antiperistaltic? Do you actually lose anything? Rimola and colleagues ran an international multi-reader study, 60 patients with Crohn's 80 MRE exams from a prospective Barcelona cohort, 10 abdominal radiologists from North America, Europe and Iran read every case twice. First round, abbreviated protocol only, T2 weighted and BSSFP sequences, no contrast, no antiperistaltic. Second round, a month later, the full contrast enhanced protocol. Readers were blinded to their own prior reads. The mix of cases was intentional, 53% active inflammation, 21% stricturing, 16% penetrating, 10% inactive. 5 novice readers, 5 experienced. This isn't a single center convenience sample read by 2 people. The headline interreader agreement was comparable between the 2 protocols for almost everything. Wall thickening, the most reliable sign of active disease, was almost perfect in both, a C1 of 0.91 for the full protocol, 0.88 for abbreviated. Edema, 0.79 versus 0.76. Strictures actually had slightly better agreement without contrast, 0.61 versus 0.50. Penetrating complications were substantial in both, 0.76 and 0.71. 2 features had poor agreement in both protocols, ulcers at 0.26 and 0.24, and fat stranding at 0.50 and 0.38, but those were poor with contrast too, so this isn't a contrast problem, it's an inherent difficulty of assessment problem. They also validated the simplified Maria score across both protocols using ileocolonoscopy as the reference standard. In the terminal ileum, S-Maria sensitivity was 96% for abbreviated and 98% for the full protocol. Specificity was 68% and 71%, essentially the same. The intra-reader concordance was the other big finding. When the same reader evaluated the same case on both protocols, agreement was almost perfect across the board. AC1s from 0.86 to 1.00. Readers were making the same calls regardless of whether they had contrast or not. And the time savings are real. The T1 weighted sequences plus the injection time added a median of 7.5 minutes to the scan. Dropping them cut scanning time by about 40%. For a patient who's been through this exam multiple times a year for years, that matters. The editorial by Ochliger at UCSF frames this well. He proposes a tiered approach. Use the abbreviated non-contrast protocol for routine monitoring and reserve contrast for cases with equivocal findings or suspected complications, not one-size-fits-all, but right-sized imaging for the clinical question. He also flags the honest limitations. This was a simulated abbreviated protocol extracted from the full exam, not a truly separate acquisition. The reader panel had subspecialty expertise, and DWI was excluded, which is part of many contemporary protocols. These are things that need prospective validation, but the direction is clear. For routine Crohn's monitoring, contrast may not be adding diagnostic value. An abbreviated T2-based protocol maintains interreader agreement, keeps the Maria score reliable, and saves 40% of scan time. That's better for patients, better for throughput, and reduces gadolinium exposure in a population that gets imaged repeatedly. Watch for the prospective validation studies. This is where MRE protocols are heading. Links to both papers in the description. I'm Melina Pektasides, and this is RadBrief.